The Role of FDA in Preventing Medication Errors, presented by Jason Flint and Hina Mehta.
My name's Ayan Ibrahim, and I will introduce our speakers. First, we have Jason Flint, the Deputy Director of the Division of Medication Error Prevention and Analysis 1, DEPA 1, within CDER. He is also the co-chair of the Office of Medication Error Prevention and Risk Management Research Team, a human factors subject matter expert for research on comparative analysis and comparative use human factors for the Office of Generic Drugs, and a contributor to the agency's guidance and industry standards on human factors. Prior to joining DMEPA team, Jason spent 13 years supporting the Air Force medical acquisition community by planning, conducting, and reporting on operational testing activities for the Air Force medical evaluation and support activity, including 2 years as their Director of Operations. He spent the previous 6 years conducting research in biology, immunology, and nanoparticle science at Cincinnati Children's Hospital and the University of Florida. Jason has a Bachelor's of Science in Biology from the State University of New York at Brockport and a Master's in Business Administration from the Warrington College of Business at the University of Florida. We also have Hina Mehta as the Associate Director for Nomenclature and Labeling for the Division of Medication Error Prevention and Analysis 2, DEPA 2, within the Office of Surveillance of Epidemiology in CDER. She has worked in DEPA since 2016 and served as a safety evaluator as well as a team leader. Prior to joining the team, Hina spent about 7 years on the drug utilization team within the Division of Epidemiology in the Office of Surveillance of Epidemiology. Prior to joining FDA, she has had over 8 years of experience working as a clinical pharmacist in a variety of settings, including hospitals, home infusion centers, and specialty pharmacy. Hina has a Bachelor of Science in Biochemistry from the Virginia Polytech Institute and State University, and a Doctor of Pharmacy from Shenandoah University School of Pharmacy. I'll hand the mic over to Jason. Thank you so much.
Thank you. So for today's presentation, we're going to cover these learning objectives. We're hoping at the end you'll be able to describe our role in pre-marketing and post-marketing activities to prevent and address medication errors, outline strategies aimed to increase the safe use of drug products, summarize how human factors can help reduce medication error, and summarize how healthcare providers can help identify, prevent, and mitigate medication errors. Hina?
Thank you very much. Once again, hi, my name is Hina Mehta. I'm the Associate Director in the Division of Medication Error Prevention Analysis 2. Today, I will present on DMEPA's pre-market and post-market activities in preventing medication errors. Next slide, please. The Division of Medication Error Prevention and Analysis, or DMEPA, is comprised of 2 divisions, DMEPA 1 and 2, and sits within the Center for Drug Evaluation and Research in the Office of Surveillance and Epidemiology within the Office of Medication Error Prevention and Risk Management. Next slide, please. DMEPA is the CDER lead for medication error prevention and analysis for drug and therapeutic biological products. The division is comprised of scientists and healthcare professionals with varied backgrounds, including pharmacists, nurses, engineers, and social scientists. DMEPA's mission is to increase the safe use of drug products by minimizing use error that is related to the naming, labeling, packaging, or design of drug products. Next slide, please. So let's start with the definition of a medication error. A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the user. A user can be a patient, a caregiver, or a healthcare professional. Intentional use, such as abuse or off-label use, are generally not considered medication errors. The important word here is preventable, because we can proactively address these medication errors before the product gets into the hands of the end users. Next slide, please. Medication errors are a burden on our healthcare system. According to the World Health Organization, the estimated annual cost associated with U.S. outpatient and inpatient preventable medication errors is $42 billion. 1 in 20 patients experience preventable medication-related harm in healthcare services. About 25% of the preventable medication-related harm was severe or life-threatening. Next slide. Historically, some design issues with drug products were not identified and subsequently were not remedied until after the product was marketed. And in some cases, the issues were only resolved after medication errors had reached and harmed patients. This was a reactive approach. However, today, design issues are designed proactively and addressed prior to products reaching the market to prevent these medication errors from occurring. We take the knowledge and learning from the medication errors that have occurred in the post-market space and apply it towards new products in the pre-market space. Next slide, please. DMEPA is involved in many different review activities. We review proprietary names, non-proprietary name suffix, labeling, packaging, human factors, formal meeting packages, citizens petitions, suitability petitions, and medication error surveillance reports. DMEPA has signatory authority on the review of proprietary names and human factor protocols. All of our reviews take into account current federal guidelines, applicable guidance for industry, USP standards, and relevant post-market experience. Next slide, please. So we will start with DMEPA's review of proprietary names. The guidance for industry, best practices in developing proprietary names for human prescription drug products, was finalized in 2020. And it outlines considerations for sponsors to develop proprietary names that do not cause or contribute to medication errors or otherwise contribute to the misbranding of the drug. DMEPA conducts a safety assessment of proposed proprietary names for drug name confusion that may lead to medication errors. Next slide, please. In consideration for DMEPA's safety assessment of the proprietary name, there's the federal regulation 21 CFR 201.10C, which states that the labeling of a drug is misleading if a proprietary name may be confused with the proprietary name or the established name of a different drug or ingredient due to similarities in spelling or pronunciation. Due to this regulation, we strongly recommend that companies conduct a preliminary screening to eliminate names with obvious similarities to names of existing products. Next slide, please. So what does DMEPA do to prevent these types of name confusion errors? DMEPA has regulatory authority over proprietary names for drug products. DMEPA evaluates proposed proprietary names to ensure that the proposed proprietary name does not look or sound like any other products on the market or does not otherwise lead to confusion or medication errors. When the agency receives a request for review of a proprietary name from sponsors, the Office of Prescription Drug Promotion, or OPDP, reviews the name from a misbranding perspective. For non-prescription products, the Office of Non-Prescription Drugs conducts the misbranding review. The Office of New Drugs, or O&D, which is organized into different divisions by therapeutic areas, then provides input on misbranding and safety concerns based on clinical chemistry or pharmacology data that may impact acceptability of the name. When we receive feedback from both OPDP and OND, DMEPA conducts a safety assessment of the name for a risk of drug name confusion that may lead to medication errors. Next slide, please. In the misbranding assessment, consideration is made on whether the name overstates the efficacy, minimizes the risk, broadens the indication, or makes unsubstantiated superiority claims for the product, or is overly fanciful by misleadingly implying unique effectiveness or composition, or is otherwise false or misleading. Next slide, please. As part of DMEPA's preliminary safety assessment of a name, we look to see if the name incorporates characteristics that may lead to medication error. For example, we review the name to see if it includes the presence of a United States adopted name or USAN stem, or medical abbreviation such as BID or IV, which could inadvertently be a source of error. After DMEPA completes the preliminary safety assessment, we then evaluate the name for additional safety concerns. When we evaluate the safety of a proprietary name, we consider many potential sources of error, including the spelling of the name, the pronunciation of the name, the appearance of the name when it's scripted throughout the medication use process, including prescribing, dispensing, and administering. And we look at the name as part of the computerized provider order entry system. We assess the similarity of names using FDA's Phonetic and Orthographic Computer Analysis, or POCA. We also conduct prescription simulation studies internally to see if the proposed proprietary name is confused for any other currently marketed products. Next slide, please. As part of the assessment of the risk of name confusion, we also consider product characteristics and whether they increase or mitigate the risk of error. For example, here is a prescription written for Avandia. The prescription was misinterpreted to be for Coumadin. We note that the addition of the orthographic similarity between the names, the products have overlapping product characteristics, such as the route of administration, the dosage form, strength, and dose, which may contribute to the error. Next slide, please. In this example, Dorazol is a prescription corticosteroid eye drop used to treat inflammation and pain following ocular surgery. Dorazal is a prescription strength wart remover. Both products come in small application bottles. In a case reported to the Institute of Safe Medication Practices, a pharmacist misread a doctor's prescription for Dorazol eye drops and dispensed Dorazal wart remover. The patient instilled the Dorazal wart remover into the eye. Of note, Dorazal eye drops are to be used after ocular surgery, which may have led the patient to have difficulty reading the carton label, which states, not for use in the eyes. Next slide, please. We note that the introduction of computerized provider order entry, or CPOE, has helped to mitigate errors associated with interpreting prescriber handwriting. However, CPOE can also be a source of error. Electronic prescribing is not error-free. There are differences in CPOE systems, as some systems display pick lists that start with the same 3 letters that were typed in, whereas other systems display all options that contain the letters that were typed. For example, name confusion has occurred between Brintellix and Brilinta due to the same 3 overlapping letters. After typing the first few letters of Brintelix into the computer system, Berlintec was incorrectly selected. Since then, the name Brintelix was officially changed to Trintelix in 2016 to mitigate the risk of this error. Next slide, please. So we will now move to DMEPA's review of container labels and carton labeling. The guidance safety considerations for container labels and carton labeling to minimize medication errors, which was finalized in May 2022, focuses on safety aspects of the container label and carton labeling design, and provides a set of recommendations for industry to ensure that products, container labels, and carton labeling are designed to promote safe use of the product during initial prescription, procurement, preparation, dispensing, and administration. Next slide, please. When DMEPA reviews the labels and labeling, we ensure that critical product information appears prominently on the principal display panel, or PDP, to maximize readability. The principal display panel is a panel of a container label or carton labeling that is most likely to be displayed, presented, shown, or examined by the end user. The proprietary name, established name, which includes the dosage form, the strength, route of administration, and important warnings and cautionary statements are considered to be critical product information that should be displayed on the principal display panel. Other information on the principal display panel, such as the net quantity statement, manufacturer name, or the manufacturer logo, should not compete in size and prominence with this other important information. Next slide, please. We encourage companies to use the side panels and back panels to display non-critical information, such as the product strength equivalency statement, lot number, expiration date, and recommended dosage statement, and storage, in order to maximize the prominence of the most important critical information on the principal display panel. Next slide, please. In our review of the product's label and labeling, we evaluate whether the font is easy to read and not lightweight or condensed. Published references recommend a large font size, such as 12-point sans serif, to improve readability. We also look at the color contrast between text and container or carton background color to ensure adequate legibility of the text. We recommend that companies avoid color combinations that are difficult to read, such as yellow text against a white background. Next slide, please. To ensure that patients receive the correct product, the proprietary name and established name or proper name should be the most important information on the label. Per Federal Regulation 21 CFR Part 201, the established name should be at least half the size of the proprietary name. The established name includes the dosage form. Next slide, please. The product's strength is taken into consideration in reviewing a product's strength too. So we want to ensure that the strength is presented in metric units of measure, as opposed to any other unit of measurement. To prevent miscalculation errors, the unit of measurement for the product's strength should be consistent across the prescribing information, carton labeling, container label, and instructions for use, if applicable. For small volume parenteral products, the strength should be expressed as the total drug quantity amount per total volume, followed in close proximity by the quantity per milliliter enclosed in parentheses. For dry powder parenteral products, The strength should be expressed as the amount per container. And finally, for blister packs, the strength should be expressed per unit to prevent confusion as to how much product is contained in a single unit compared to the total contents of the entire blister pack. And in some circumstances, we may also include dose on the blister pack. Next slide, please. We also review the net quantity statements in relation to the product strength as well to minimize the risk of confusion. In the first example, here, Remeron is available in both 15 milligram and 30 milligram strengths. We note that the net quantity, 30 tablets, is prominent and may be confused as the product strength. When we think about how we generally read labels from top to bottom, the net quantity is more centrally located, whereas the product strength is less prominent in terms of where it is located. Thus, we would recommend that the product strength is relocated to a more prominent location, and the net quantity is less prominent and relocated away from the product strength. In the second example here, Temodar, we note that the strength is located in the upper right corner next to the quantity. The strength statement is not very prominent. In the revised label on the right, the strength is much more prominent with an increased font size and is relocated away from the net quantity. Next slide, please. If there's a product that is available in multiple strengths, we want to ensure that the product's strength on the container label and carton labeling has adequate differentiation among the other strengths in the product line to prevent errors when a patient receives the raw strength. In this example of my drug, on the left, it is difficult to see the difference between the two products. Therefore, we recommend that techniques such as boxing and/or color differentiation are implemented in order to ensure that the product strengths stand out. Next slide, please. As I mentioned before, the route of administration must be on the principal display panel for non-oral drug products. When we review labels and labeling, we ensure that the route of administration is not abbreviated, as certain abbreviations or acronyms or symbols have led to confusion. Additionally, we recommend expressing the route of administration using affirmative or positive statements, as users may overlook the word not, depending on how the statement is positioned on the container or carton labeling, or if something covers the word not. Next slide, please. In addition to the route of administration, all warnings and critical information on the labels and labeling should also be affirmative statements. For example, the label states, for intravenous infusion must be diluted before use. These statements are affirmative and help the healthcare provider clearly identify how to prepare and administer the product. When information is included on the labels, we also want to think about whether the statement is helpful to ensure safe use. In this example, we have a bottle for Astradax XL 1 milligram. The bottle states once daily, as the product is an extended release formulation. According to a report from ISMP, a healthcare provider prescribed a patient a dose of 6 milligrams once daily. However, instead of following the correct directions on the pharmacy label, the patient took 1 milligram once daily, as they had been following what they thought were dosing instructions on the manufacturer's label that stated once daily. Next slide, please. Finally, when labels are overcrowded, important information may be difficult to read or easily overlooked. Therefore, we ensure that lines or blocks of text are separated by sufficient white space and non-critical information is located on side or back panels or in the prescribing information. As I previously mentioned, as part of our review, we ensure that error-prone abbreviations, symbols, and dose designations are not used on labels and labeling. For example, IU, which stands for International Units, may be confused as intravenous route of administration. The Institute for Safe Medication Practice has a list of abbreviations that have been misunderstood or misinterpreted, and we typically use that list in reviewing product labels and labeling. We also ensure that text is not superimposed by images or logos. In this example here, the image is superimposed over the strength and dosage form on the primary display panel. Next slide, please. So you may ask yourself, why is post-market surveillance necessary? There's a limitation of pre-market clinical trials, as trials are conducted under controlled conditions and may not use the final approved name, labels, labeling, and packaging. The number of patients tested is too small to detect serious but rare problems, and trials are often too short in duration. Although FDA has a robust program to identify potential errors and address them prior to approval, medication errors remain a significant burden on public health. Post-market surveillance allows us to monitor error reports and address those causes of errors that may be related to a drug's name, label and labeling, or packaging or design. Next slide, please. However, we know that medication errors are underreported as there is no requirement to report medication errors to the FDA. Thus, the extent of underreporting is unknown, and the reports that we do receive are just a tip of the iceberg. Next slide, please. We recognize that there are barriers for reporting medication errors, such as fear of punishment or litigation, organizational culture, the amount of time needed to submit a report, not knowing how to submit a report, or even just embarrassed of having been involved in a medication error. However, it is so important that as healthcare providers, you submit reports of medication errors to the FDA so we can quickly correct the problem. If we don't know about the issue, we are not able to correct the issue. Now I will turn it over to my colleague, Jason Flint, to present on product design and human factors.
Thanks, Ina. So we'll continue the theme on prevention of medication errors by looking at product design. Next slide, please. So reference to the safety considerations for product design to minimize medication error. The FDA expects manufacturers to investigate, to understand, and correct identified risks. And there are analytical methods that can be used to develop drug products. We'll talk about those a little bit later. The expectation is that we're building safety into the product design, and we expect that these methods are applied early in drug development and throughout the drug product's life cycle to include the post-market space. All of this will enable safe and correct use. Next slide. It's important for us to understand that when we talk about the product itself, we're talking about the entirety of the drug product user interface. That refers to all products of the product that a user interacts with, so sees and touches, and occasionally for some newer products, hears. This includes packaging, instructions for use, the product labels, and also the delivery device, constituent part, and any other associated controls and displays that might be used. Next slide. The most effective strategies that we can use to mitigate risk is focusing on improvement to design of the drug product user interface. We want to consider the effect of each design choice on the end user. And we can evaluate that using proactive risk assessments or use-related risk assessments before finalizing your design. We also want to evaluate how and why problems have occurred with similar products. By doing this, you can identify error-prone features and eliminate them from your design, and then prevent those same errors from occurring when it comes out to the market. So sponsors should consider lessons learned to minimize the risks associated with their product. Next slide. So when we talk about container closure design, we want to consider whether this is safe for the route of administration and whether it's appropriate for the intended users. We want to avoid use of container closure that implies a route of administration other than the route intended unless there are no other options available. So for example, if we look at the hand healer, this requires the user to take a capsule coming from a blister pack and put it into the device and puncture that for inhalation. And so the errors that we've seen with this type of design is people look at the capsule in the blister pack and ingest the capsule rather than inhale it. The ultrasound example looks like an eye dropper, but is actually a lotion for a topical application. And then Gleolan is in a vial that provokes a mental model of injection. I may need to remove the cap, use the syringe to extract the liquid, and then inject it, but in fact it's for an oral solution. And so you should avoid these mismatches if possible. Next slide. When we think about product strength, it's important to review for inconsistency between the drug product strength and the dosing. When you require multiple units, so for example, multiple tablets, capsules, or vials, or syringes to achieve a single dose, you run the risk of dose errors due to miscalculation or forgetting how much had already been administered. Next slide. When you do when there is a co-packaged dosage delivery device, it should be consistent with the recommended dosing regimen or directions for use. The printed matter appearing on the dosage delivery device is considered labeling, and so those markings must be easy to read. So dosing devices for oral solutions should use metric unit markings instead of things like tablespoons. So, as an example from my SMP, here the user was supposed to deliver a 0.6 milliliter dose by feeding tube. They were given a 10 milliliter syringe. This 10 milliliter syringe can technically accommodate doses in 0.2 milliliter increments. However, only the markings denoting the full milliliter doses are labeled with numbers. So in this case, there's a mismatch between the dose to be delivered and the dose that can be measured. The patient was confused about which markings to draw up the dose since the syringe didn't have a 0.6 milliliter labeled marking, but it did have a very closely matching 6 milliliter labeled marking. So in this case, it would have been much better if a 1 ml syringe was provided. That 0.6 milliliter dose would have eliminated the potential for a tenfold overdose. Next slide. So I want to talk about some of the tools that we can use to inform our design. And this includes human factors. So human factors is the application of knowledge about human capabilities, physical, sensory, emotional, and intellectual, and limitations, and applying that to the design and development of tools, devices, systems, environments, and organizations. Next slide. So the International Ergonomics Association provides a good definition. Ergonomics, or human factors, is a scientific discipline concerned with understanding interactions among humans and other elements of the system, and a profession that applies theory, principles, data, and methods to design in order to optimize human well-being and overall system performance. Next slide. Now, that was a lot in that definition. So just to keep things simple, human factors is really understanding the system's compatibility and ability to support people's needs, abilities, and limitations. We look at the picture of the ICU. and recognize that this is a situation where there's a lot of information being provided. It's very crowded, probably very high stress, high noise, and understanding that this use environment can influence and does influence people's needs, abilities, or limitations. And so if I'm providing or designing a product from this space, I have to consider those things. Next slide. So for related terminology, there's use error and medication error. A use error is a user action or a lack of action that's different from what is expected by the manufacturer and caused a result that was different from the result expected by the user and was not caused solely by device failure and did or could result in harm. This is from the CDER guidance on usability engineering. Now, medication error is a preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare provider, patient, or consumer. Next slide. There's a difference between medication error and malfunction, although they can be related. Medication errors can arise from many causes not related to device malfunction. So products that may look alike, difficult to read labeling, those mental model mismatches, for example. And then there's also malfunctions. Malfunctions can result in medication errors, but are not really use related. So an auto injector might jam because the device components didn't meet the specification. That caused the patient to miss a dose, which would be the medication error. Next slide. So I want to point out an important key point. I think when a lot of people hear human factors engineering in the context of the FDA, they think about human factors validation study. This is a simulated use study done at the end, right? Full user interface, simulated use with intended users in the intended use environment to validate the things that I've done to mitigate risk. But it's not just validation. So we want sponsors to follow a human factors engineering process when they design and develop their medical product. Next slide. So this is a process overview of human factors engineering. The source of the image is actually the NCAME HE75 standard for human factors from 2009. I do want to point out that that standard was updated in 2025, but this image is a little bit easier to go through in a presentation like this. So we'll keep that. So I want to start the HFE process early. I want to identify the intended use, the intended users, and the intended environment. I want to then identify use-related hazards. I want to identify what the risks associated with those are. And I want to think about risk controls and implement them. So things like device design or labeling or these types of things. And then I want to validate that safety of use. Now that may be informative studies early on, but eventually HF validation study. At the end of those efforts, you'll make a determination. The risks that we identified in those studies acceptable or not. If not, then I need to go back and identify more risk controls and start that process over. Or, and this does happen, I identified a risk that I didn't identify before, right? And so I need to consider whether I need to add additional risk controls for that. All of this gets documented in the process and then continues on into the post-market space. So there may be risks that you did not identify in a human factors study or validation study that you may identify through monitoring use of your product, and then again make a determination in terms of what can I do to control that risk, and is that risk control effective? Next slide. So one of the main tools that we use, or that can be used, is a use-related risk analysis. This includes comprehensive evaluation of all the steps involved in using the product based on a task analysis. For each of those tasks, we want to consider what errors a user might commit or tasks that they might fail to perform. and then the clinical consequences of those. And this should be more detailed than something like just underdose, like what's the actual clinical consequence. And then I need to determine what risk control strategies I might be able to use to reduce risk to an acceptable level. And then how I'm going to validate that. How do I identify that the risk control strategies would work? Your use-related risk analysis, and I think we talked about it previously, is informed by known use problems with similar products. And so you can look at post-marketing, you can look at some use information from those to inform your own use-related risk analysis. Next slide. Another tool, a piece of information, is human factors validation study and root cause analysis. So this is a simulated use study with the intended market product, with the identified intended users in the simulated use environment to determine where use errors are occurring, if any, where use difficulties might be occurring, where there might be close calls. We get a lot of questions about close calls versus use errors, and it really hinges on whether the error actually occurred, whether there was an intervention ahead of that. So an example I might use for that is if I'm watching a user working with a pre-filled syringe try to deliver their dose, though it doesn't press the plunger, but then later recognizes, wait, the cap was on, so I'm going to correct that. But I didn't, and then give an injection and there was no dose miss, that might be considered a close call, as opposed to use error. But it requires root cause analysis to investigate why that occurred. So was there something in terms of prominence or something about the cap, for example, that made them not understand they need to remove it? From those root causes, we'll determine what risk control strategies are needed, and if any, for additional, and then whether or not I need to validate those changes. How do I identify that the risk control strategies are going to be successful at reducing risk and whether they introduce new risk? Next slide. So the root cause analysis is used broadly, but also used at the end of human factors validation studies to describe a wide range of approaches, tools, and techniques to uncover causes of the problem. So generally, we're looking at, our initial look is at the visible problem, right? Well, I can keep asking questions about, okay, well, why was that? That might be the first level cause. There might be something that led to that. Or to keep asking those questions to get to the root cause. Slide. So user interface design and use errors. There may be design flaws in the user interface that can allow or even induce use errors. Some of the examples previously, those mental model mix-ups, right? It's this looks like a device for delivering medication to the eye, but it's actually lotion, right? That's a design issue. But you can use human factors methods to address use-related hazards and to minimize use-related risk before or after products reach the market. Labeling and training can help. They're considered very low-level risk mitigation strategies. They don't replace good design. And if you're using the human factors engineering process, you can iterate through your design to address these as they come up and before they hit the market. Next slide. So in summary, you can use the HF engineering process to minimize use-related risk. That process does continue into the post-marketing space. And there are tools and data that you develop throughout that HFE process that can be helpful. They can inform your product design. You can help determine root causes of post-market signals. And then you can focus efforts to address those signals that need to be addressed to reduce medication error. And so we provided some resources. We have the best practices in developing proprietary names, safety considerations for container labels and carton labeling, safety consideration for product design to minimize medication errors, applying human factors and usability engineering to medical devices, And the most recent application of human factors engineering principles for combination products, or Q&A guidance that came out in September of 2025.